Now, this topic here is one of the limiting factors of a practice, and I don't think many doctors realize it, that it's your notes. Your notes can be a very limiting factor in your practice, and specifically, I'm going to talk about the soap notes. And the point being is, if you are not done, the two main points of reference here is, number one, it can be a very limiting part of your practice and limiting your growth. And a lot of doctors don't even know it's happening. I've seen it happen so many times, but the doctor doesn't even know it's limiting your growth. In other words, if you are still having to do notes, soap notes, after the patient has left the room and before you've seen another patient, you're limiting yourself tremendously. You will not be able to grow your practice if at the end of the day, or between patients, you're trying to do your soap notes. That's called a terrible system, and most doctors don't even realize it. They do it. They'll not do their soap notes, at the time of that interaction. So when they're done with that interaction, the notes are totally done. So instead of doing that, they have a really bad system. So they'll see another patient, and next thing you know, they're doing notes at the end of the day. Or they're trying to do them between patients, if there's a lull in patients. And I just want you to know that if that's you got a major practice growth problem. And I've done this with several doctors, and I've talked, and I had one doctor say to me, he said, but that's my system of doing notes. In other words, he justified it. So here at the end of the day, he still had to do all these soap notes. And then I said, you can't do that. You can't expect to grow a practice. And at the end of the day, it's too damn negative. It's a huge negative feedback loop. It's a total practice killer. And then the doctor says, but that's my system. He couldn't even see that he had a shitty system. Just because it's a system doesn't mean it's good. It just means it's a system. That's all it means. So many times I've seen doctors just be inhibited from their practice growth. I remember I got one doctor that he's still writing. He's still writing. And so he'll treat the patient, and between patients, he's got a stack. So every day he's got like a stack of notes that he's trying to fill in the soap notes. And at the end of the day, he's trying to fill in soap notes. And, just a major negative. It's who wants new patients if that's what you're getting at the end of the day? Nobody wants new patients. Nobody wants new patients to get more of that. And by the way, you won't even have the time. So it's a major practice inhibitor when you don't have your soap notes done at the end of that visit. So if you don't do it, you got a bad system. You're not doing it right. You're not documenting it right. You got a bad system. And then number two is this is how you're going to get paid. You have to have the basics down of your biomarkers, and I've said this over and over. If you don't have the biomarkers down and if you don't have them quantified, you're not going to get paid. And worse than that, when they go and ask for your records and they see that you, like I have one doctor, he does no re-exams whatsoever. Well, of course, he recently had an IM meeting and he got his butt kicked because he didn't have the supporting documentation that was necessary. But the big problem is they'll ask for money back. So when you don't have your initial exams, your re-exams, your functional capacity indexes, and especially your soap notes, if you don't have a soap note and it's not qualified soap note, then they can totally ask for that money back. And if it happens enough, it's called fraud. It's called billing for services that were not needed. You may have done them, but they weren't needed. And so there does get to be a point, depending on the amount of money we're talking about, where the insurance company can just flip it over and say, hey, this is fraud. You're just billing us without supporting the need for care. So it has three really negative ramifications when you have bad soap notes. One is it'll limit your practice. Two, it can create civil problems. Civil meaning cost you money. They'll ask for money back. And I know many doctors that have $30,000, $40,000, $50,000 asked back. I had one doctor that the insurance company asked for $130,000 back, and they did it because he went through his notes, and he didn't have the supporting documentation for what he billed, but the insurance paid him. Well, they wanted their money back now, and they just stopped paying you. By the way, they just stopped paying you. So everything from that insurance company just stops. The spigot gets cut off. And then the third component is eventually it can turn into criminal. This can eventually be a criminal activity, depending on the volume of what we're talking about here. So I just wanted to cover some major components to stop that from happening and really just simplify this. And I just tell you, when I was practicing and I trained doctors, here was the rule. The rule is they were not allowed to leave that room when we treated the patient, and they were not allowed to leave that room until the soap note was totally done. They were not allowed to see the next patient until that soap note for that patient was totally done. Because I knew that if that doctor didn't do it, I knew it was going to be a major practice inhibitor, number one, and then I knew it could possibly lead to civil charges, criminal charges, but I also knew it was going to create some unbelievably terrible bad habits. So if you're one of those doctors that's seeing patients and you are not 100% with your soap notes, done. In other words, you're done. You don't have to go back and make modifications. You're done. You got a bad system. You are limiting yourself tremendously. And you need to change that. You cannot have soap notes accumulate and then do them at the end of the day or once a week or whatever and expect to have practice growth. That is an unbelievable negative situation. You're not going to want new patients because that means more soap notes and you staying later. That's what it means. It doesn't mean, and that turns out to be a negative thing, not a positive thing. So the simplicity, so to cover that, I wanted to just cover some of the basics of the soap notes and what needed to be on it, but I wanted to simplify it. I wanted to show you how simple this was, how simple it is, how simple it can be. And my soap notes took an average of 7 seconds to 12 seconds. 7 seconds to 12 seconds at the end of the visit. And I'm going to share with you how I did that. So they were done. In other words, when we finished with that patient, we had a micro dictation, and we covered the main points immediately for that soap note in the micro dictation, and we hit off. And that was it. It took 7 to 12 seconds, and that was it. We were done. We were seeing the next patient, and then we were seeing the next patient. And that's what it should be. It should not be going on, and at the end of the day, you got to write soap notes. If that's your situation, you've got to realize you've got a really bad system. You're not going to be able to grow your practice. You cannot continue that. And remember, there's a lot of stupid stuff you can do when you're seeing 40, 50, and 60 visits a week. You can do a lot of stupid stuff and not even realize it's stupid and it's hurting you because you're going too slow. You got all that time on your hand. But those are the same things that now totally inhibit you from growing. And a lot of times the doctors don't even know it. They don't even know some of these major inhibiting factors that are happening. And then a lot of times, to be honest with you, I find out by accident because I just take some of this stuff for granted. I kind of take for granted that a doctor knows how to write a soap note and he's done with the soap note before he sees the next patient. And I'm like, boy, was I wrong. I can't believe how many doctors don't do it that way. And then they got all these bad notes and they're not done, and then they have to spend extra time. And I'm like, man, what a nightmare you got. I'm like, what are you doing? So let me simplify how I did a soap note in 7 to 12 seconds. So you can be done, and it's totally fulfilled. In other words, you have to fulfill the components of the soap note legally, and you're substantiating the need for care. So, of course, the SOAP notes are the subjective, objective, and the assessment plan. Let me go through some of the big stuff, and then I'm going to go into the simple. So I'm going to go into the big, boring stuff, and then I'm going to show you the real world, the practical application. So when you look at the subjective component, you see initially the patient's chief complaint, a brief statement of the purpose of the office visit, describes the patient's current condition in a narrative form. The symptoms are recorded in the patient's own words. All information is communicated to the provider by the patient, includes all pertinent and negative symptoms, pertinent medical history, surgical history, family history, social history. So any of these subjective factors are also recorded. Subsequent visits of the same problem, they briefly summarize the history of the present illness, including pertinent testing, the mnemonic that refers to and the information the physician should elicit is the OPPQRST, which most people are familiar with, or the LOCQSMAT. And so that's what you're looking at here is the OPPQRST, onset, location, duration, character, alleviating, aggravating factors, radiation, temporal pain, severity, OPPQRST. So these are very common factors. Most doctors are pretty aware of it. And then you have the LOCQSMAT, just another mnemonic. A little bit more information so you can see its location, onset, chronology, quality, severity, modifying factors, additional symptoms, treatment. So OPPQRST is typically the one that I use, and that was the standard. But again, I'm going to simplify this. I'm going to make it real simple. So here is what we call the subjective practical chiropractic patient. So remember, chiropractic is very simple. We don't see, like a general practitioner will see a myriad of things, from kidney to liver to stomach to lungs, just all kinds of systems. A chiropractor will not. A chiropractor will, remember the statistics, 84% of all the patients that see a chiropractor are for back pain, neck pain, and headaches. Another 7% is extremities, neuromusculoskeletal. So 91% of the chiropractic patient is neuromusculoskeletal. That's the statistics. Only 1% of the 8% of the population that's in chiropractic. Only 1% each is for a visceral problem, asthma, allergy, bedwetting, or something like that. 1% of 8%. That's like 0.02%. That's how small that number is. So 91% is neuromusculoskeletal. So what we will see is very straightforward. So from a practical standpoint, the subjective component of the SOAP note, each chief complaint separately. So of all the different diagnoses you do have, they do have to be fulfilled individually, not cumulatively. So if you have 3 diagnoses, then I'm going to, like I have back pain, neck pain, and headaches, I have 3 different subjective complaints in my SOAP notes that I have to correspond, all 3, to make it legal. And legal meaning for me to be able to bill a third-party carrier, and this is under Medicare guidelines. So quantified, so the intensity, so we want each individual complaint, and then we want the scale, preferably, typically we'll have the pain diagram, or we'll have a scale of 1 to 10. And we want to quantify these, and I always like the scale of 1 to 10 because of the variability. And then frequency, constant, daily, 3 times a week. In other words, of course, it depends on how often I'm seeing the patient, but is it constant and is it irregular? Okay, so frequency. Remember, these are biometrics. Frequency is a biometric, meaning it helps to establish the need to get paid. It determines the effectiveness of your care, determines if the patient's is right on path to what they should be doing. It determines whether you need to modify what you're doing. It determines whether maybe not you need a second opinion. So frequency is not just, everybody's familiar with the intensity, but also you want to consider frequency, because that will be a component. So see, these are good variables to establish the need for care also. So I've got each of whatever my complaints are. Let's say there's 3, back pain, neck pain, headaches. Then I'm going to have a scale of 1 to 10. Well, now I got 10 possible biometrics, 10. And then I also would have a frequency. So if I had those 10 plus any kind of frequency, I've got a lot of variables here that are shifting, and they will shift slightly. These are, remember, the SOAP notes are trend lines. The main trend lines are the re-exams. That's where you make your major decisions, is the re-exams. And then the SOAP notes are the micro trend lines to support the major trend lines in your decision making for your therapeutic protocol. What treatments you're using, what frequency, what intensity, all that stuff. So that is the subjective part. So that's the simplicity of how easy I would be done with subjective. So a patient comes in, and I'll just tell you typically what happened. Patient comes in. Hi, Mary, how's your day going? All right, before we get started, Mary, remember we have a protocol of exactly what to say to move a patient through the adjustment procedure. So you're not just sitting there for 10 minutes talking to somebody. So, all right, Mary, before we get started, let me just check your headaches. And remember, I typically, on the very first regular visit, I've educated the patients. On the fifth visit, I'll say, hey, Mary, by the way, on every visit when you come in, I'm going to ask you on a scale of 1 to 10, each of your chief complaints, the intensity and the frequency, how often you're noticing it, and whether it's constant or irregular. So that'll be the first thing we cover on every visit. So I've trained that patient. She knows when I come in, that's what's going to happen right off the block. I've trained them. And I'll remind them, because patients always need to be reminded. So I come in, hey, Mary, how's your day going? All right, Mary, before we get started, let's go ahead and let me get your scale down. Where's your neck pain, scale of 1 to 10? Low back pain, scale of 1 to 10, headache, scale of 1 to 10. And how about the frequency of the neck pain? How about the frequency of the, and I'll menu it, constant, irregular, daily, 3 times a week, whatever. You know, I'll menu them, because they won't know 3 times a week, twice a week, once a constant or irregular. They won't know that. So I'll menu that to make it easy for them to pick from my menu. And now I have some good metrics. Remember, any of these variables that are changed help to establish the need for care. In other words, get you paid. Okay, so that's the simplicity of the subjective component. That's how fast that went for that SOAP note. Now remember, the fastest way to do this is with microcassette recorder. So this was done, I'm holding a little digital microcassette recorder, and I'm talking into the, and this is what it would sound like. All right, today it's the date and the patient's name. Today's date is whatever the date is, patient's name. And then, all right, Mary, before we get started, scale of 1 to 10, how's the headaches? How's the frequency? All right, how's the low back pain, scale of 1 to 10? How's the frequency? How's the neck pain, scale of 1 to 10, and the frequency? And then I just go to the microcassette recorder. So, okay, Mary says a scale of 1 to 10, neck pain is 5, frequency constant, low back pain is 7 on a scale of 1 to 10, irregular, and headaches are irregular, and scale of 1 to 10, there are 3. That is how that sounded. That's how fast I just did the subjective part of those notes. And I did it right in front of the patient. I mean, I just asked her, she told me, and then I hit click, and I rattled them off, and it took me about 4 to 5 seconds to say that. I'm done with the subjective part. Now, the objective portion. Information that the provider observes or measures from the patient's current presentation. The objective component includes or can include vital signs, measurements, weight, findings of physical exam, including basic systems that are affected, possible involvement, results of laboratory or diagnostic tests, medication list. Okay, now this is the definition of the objective. Now, from the practical chiropractic standpoint, you must include 2 evaluation and management procedures in the objective standpoint. Now, which have the highest probability if 91% of the chiropractic's patient is neuromusculoskeletal, which 2 evaluation procedures will I have the highest probability of those biomarkers being positive? It will be range of motion and muscle. Those are the 2 that will be commonly used for the evaluation and management procedures. So for the objective portion of a SOAP note, you have to include those 2. You have to include 2 evaluation management procedures, and those 2 have the highest probability because of the chiropractic practice, being 91% neuromusculoskeletal. So when we go to range of motion, remember there's three ranges of motion. So there's range of motion, there's gross active range of motion. That's a quantifier. There's also the passive range of motion, overpressure passive range of motion. And then there's joint motion. And then remember, you always want to quantify that motion. And then you want to document the muscle component. And by the way, this also helps to establish the need for care for your muscle therapies, whether it's muscle relaxing therapies or whatever. Now, remember, spasms are different from tension. You will get paid for spasms. You won't get paid for tension. So spasms are involuntary muscle contractions, involuntary. So just be aware of that. So I'm going to pay attention to the muscle tone and spasms. So having said that, I'm going to give you an example now. So Mary's my patient. I already did her objectives, her subjective. I talked into the microcassette recorder after I finished the subjective. And then I go to the objective, and I go, okay, Mary, let me go ahead and check you. Sit right here. So I directed her. Now everything's moving. The whole process is moving right now. So I will typically palpate the patient. The typical, typical motion palpation. So depending on the severity of the patient, whether it's the neck or the low back, I will check joint motion, and that's the classic chiropractic fixation. And that is really the motion that I would put most of attention to, because that's the motion that you're going to have. Remember, you will have normal active range of motion way before joint motion is cleared up. So your highest probability of an abnormal positive finding in the range of motion category is joint motion. It is not active range of motion or overpressure. So I'll comment. But typically the motion that I'm checking for is joint motion, and that's typically with motion palpation. And that's that thing called a fixation. So typically, whether it's the neck, I would just check and move for the fixation in the neck, whether it's the thoracic area or in the low back. And that's how I would check not only for a fixation, but also for muscle tension, pain or tenderness. And it happens real fast. And I mean, it's not like I'm doing a full-blown exam. I mean, it happens within, 5 to 10, no more than 15 seconds I'm literally touching the patient, checking the fixation, and then I adjust them. And then I'll go to the next region. Thoracic, okay, let me lay on your stomach. Typically it's sitting cervicals. I'll check the fixation there. And then go, like in this case, we have the three diagnoses that we're talking about are headaches, neck pain, and back pain. So I check the motion. I'm going to pay particular attention to the motion of the atlas and axis and its rotation. So I'll check that with the patient. And then I'll check left and right lateral flexion, intersegmental left and right lateral flexion for fixations from C2, 3, 4, 5, 6, and 7. And so now that's how quickly I know where there's range of motion problems, specifically joint motion. Okay, so I'm done with that. And then I also, when I'm doing that, I test, I'm checking for pain, because when I'm doing the motion palpation, I'll ask the patient, any tenderness there, any tenderness there. And the word to use is tender, not pain. People will deny pain. Any tenderness there. And then also I'm going to be palpating muscle tension. So I'm gathering all of this data for my objective. It's all happening simultaneously. So I've got my range of motion. I got my fixation. I checked where the restrictions are. I see where there's muscle tension or spasm, and I check for tenderness. All that's called, just pushing on the joint as you move it and saying, Mary, is that tender? I mean, that's how simple it is, whether it's in the neck, the mid back, or the low back. So that's the neck. So we got the headache and the low back, or in the neck. And then the low back, I'm going to put them prone. So I would have adjusted them. I would have adjusted their neck. Okay, Mary, have you lay on your stomach? And then I would do the same thing. I'm gonna check motion palpate. I'm just gonna do joint pressure. in S1, left SI, right SI, L5, L4, L3. And then I'll say to them, any tenderness as I go into joint pressure. Each of those joints, I'll just go in there. Tender, is that tender? Is that tender, very tender? So now what do I know? I know my joint fixations. I know if there's tenderness, and I know restrictions or muscle tension. I know all three of those, and I found them out literally in 5 to 15 seconds for the objective component of my SOAP notes. So that is what I recommend, and why I recommend those two evaluation procedures, range of motion, joint motion, specifically of the ranges of motion. If you're having trouble with active range of motion or overpressure, then go ahead and document it. But that's not typically what we're dealing with as chiropractors. And if they do have it, those clear up pretty fast. It's the joint motion, that thing called a fixation, that lingers around and causes problems. And that's what you need to document. So we got the joint motion, and then we also have the documentation for spasms and for pain. So we have muscle spasms. And when I say it, they're going to be in generic, they're going to be in broad ranges. They're not going to be each individual muscle. So that's the objective part. So how would that sound? Well, let's go, right now, I'm not going to stop what I'm doing with the patient to fill that out. So I'm going to complete the whole evaluation and the treatment of the patient. So I'll give you an example of what that sounds like in just a second and walk through it all. But let me hit on this one first. So now you have the assessment. Well, I'll tell you what. Let me go back and do this since we're on it. But essentially, I'm done with the patient. The physical part of me treating the patient is done. Now I'm just going to document the SOAP note. So in the SOAP note, how it would sound like this. Now remember, I have a micro cassette recorder, and it's very fast to talk into a micro cassette recorder versus write. And all I do with the micro cassette recorder is I upload it to an online transcription service, and all they do is type it out, and they send it back the next day, and I just make copies of it and put it in the notes. That's how simple the transcription and the note process is. I never sat around after work and wrote notes. And I didn't have to because of these types of procedures that were implemented. Now, in the beginning, what I did is I had the outline of the SOAP note on the wall. And I would just, when I was with the patient, I would just slowly would walk through the outline and talk into the micro cassette recorder. So in the first day or two, it did take a little longer for me to talk into the micro cassette recorder. But, I'd see 50 to 70 patients a day. Well, after you do something 50 or 70 times in one day, it gets to be a habit pretty quick. So by the second day, no longer the third day, it was unconscious competence. I didn't even need that outline anymore. I mean, that's how fast you just learn these things. But initially, I forced myself to do it in front of the patient because that put the pressure on me to get it done. So it took a little longer for me to learn it, but it happened real fast. And so when I was finished with the patient, it took 7 to 12 seconds for me to finish that SOAP note. So here's what it would sound like. If this is what this patient, so let's say the patient's name is Mary. So I'm done treating the patient, and I check the fixations, I check the muscle tension and tenderness. That was part of the evaluation and the treatment for that patient. So this is typically what it would sound like in the micro cassette recorder. So for the objective portion, remember we already have the patient's name and date and subjective in the micro cassette recorder. Then I hit stop. Did the evaluation of the patient and the treatment, and then I turn it, and essentially I'm done with the patient. I just tell you right now, I'm done with the patient. I'm just going to finish it right in front of the patient right now. So I'm only going to cover the objective part, and then I'll go to the assessment. So the objective part is Mary's cervical spine, C5, C6, restrictions left lateral flexion, and C2, Atlas to C1 on C2, decreased left rotation. That would have been the motion. And then I said muscle spasms, the extensor muscles, cervical region bilateral from C5 to C7. And that's how I would just group the anatomy from C5 to C7 or from C1 to C7. And then I just would group that particular muscle. Was it a flexor? Was it an extensor? I would just say whatever group of muscles that was. So that's how I would have said the muscles. The muscles would have been extensor muscle spasms, bilateral from C7, from C1 to C7, mild in nature. That would have been the neck pain. So in the low back, it was said for the low back pain, the objective or the objective assessment in the low back pain is point tenderness at L5, fixated L5 S1, restricted joint motion, and paravertebral or right. Let's say it was extensor muscle spasms in the right erector spinal muscles from L1 to L5. And that would have been how quickly I would have been done with the lumbar section. And then for the, let's say I'm going to the headache. So I'm done with the neck for the subjective or the objective. I'm done with the objective for the low back. Now I'm going to do the headaches. Remember, you have to do each diagnosis. Each diagnosis has to have these done, not cumulatively, individually within the SOAP notes. And then, so for the headaches, I would say for the neck region, the rotation from the Atlas on axis was restricted and left rotation, mildly restricted, and occipital muscle spasms and tension, bilateral up the occiput, the base of the skull. So that would have been it. That is how quickly I described motion, joint motion, range of motion. And then I would have described muscle spasms and the region they were in, and then any pain or tenderness. And that's how quickly that SOAP note would have went. And that was 3 different diagnoses. Now, when we go to the assessment, and this is where it gets really easy. The next 2 are really easy. The hardest part of the SOAP note was what I just covered, essentially for the standard chiropractic visit, is the objective. So the assessments, the medical diagnosis, the purpose for the medical visit on any particular date, list of possible diagnoses, also include any possible etiologies, the patient's progress, overall progress towards the patient's goal. The assessment will identify the treatment related to the problem, includes the etiology and risk factors assessments. When used as a problem or relevant problems, numbers and headings are included as subheadings. So in other words, in the assessment, it's only the diagnosis. So how the diagnosis in a chiropractic office from one visit to the next very rarely changes unless something happens. And you typically never change a diagnosis until you do re-exams. Re-exams are when you modify, change, add, or eliminate diagnoses. They should be done at re-exams, not at SOAP notes. So, and for the assessment part, that's the diagnosis, the 3 different diagnoses. So typically, they will remain the same. I will not add anything. So the assessment from the practical patient, remember you do list each diagnosis separately. You modify if necessary, but most of the time you're not going to modify. You're going to save those for the re-exams. And then the most common comment is going to be same as the assessment remains the same. The assessment remains the same. That is literally what I said into the microcassette recorder. The assessment remains the same for each of the diagnoses. In other words, those diagnoses are staying the same. Remember, these are micro trends. We don't expect major differences in a SOAP note from one visit to the next in a SOAP note. So that is the simplicity of the assessment. That's what I would have said after the objective part. In the assessment, the diagnosis has remained the same. If there would have been any changes, I may have said it. I may have quantified it. Maybe it went from moderate to severe, from severe to moderate, from moderate to mild, or something like that. But I would just refrain. I would just say to you, try to refrain from eliminating or changing diagnoses in SOAP notes. That they get changed at re-exam periods. Re-exam periods. That's when I would go from mild, severe to mild, or moderate to mild, or even eliminate a diagnosis or add a diagnosis. Probably the most common thing in chiropractic, if you do something, is you may add a diagnosis because the person had a re-injury or they injured themselves in another way while they were under care. Then you would just do the evaluation and document that, the brief exam, and then you would just include that diagnosis also. That's probably the most extensive in a typical chiropractic patient that you're looking at. So when I did the microcassette recorder for the assessment, that's what it sounded like. I said assessment, for each of the diagnoses listed here, they remain the same. That is the simplicity of the assessment part. Now, the plan is what does the provider will do to treat the patient's concerns. The plan is also the goals of the therapy. The plan addressed each of the item of differential diagnosis. For patients who have multiple health problems, problems that are addressed in some notes, a plan is developed for each problem. A note of what was discussed or advised with the patient, or a review for follow-up generally included. And the plan itself includes various components. So it could include some of these other components. But essentially, the plan is your treatment protocol and the frequency of treatment. That's what your plan is. So the plan, overwhelmingly, is exactly the same scenario as the assessment. And it would be to continue responding as, over 80% of the time, it's going to be in the microcassette recorder, it's going to say, responding as planned, it would say continue as planned. That is literally the simplicity of what it would sound like in my microcassette recorder. That is how, unless something unusual happens. So what typically unusual happens in the plan category for a chiropractic patient? Anything unusual that happened, modifications, restrictions, flare-ups, did you have to modify something, change something, things of that nature. But again, that's rare. So when we're talking about the plan, it's also a very simple, it pretty much stays the same. So the practical application is no changes, continued as planned. Patient is progressing as expected, no changes, continue as planned. I can't tell you how many times I've said that into a microcassette recorder. Patient is continuing as expected, or progressing as expected, continue as planned. And you might want to modify, if they're not responding as well or they didn't respond as well, you could add that in. But I'm generally not going to be making therapeutic changes from one visit to the next in a SOAP note. That is not how chiropractic works. That happens with re-exams. When you do re-exams, that's when you change the directions. That's when you change patient schedules and frequencies and therapies, and that's when you make the major modifications, not in SOAP notes, unless it's something happened. But in a typical chiropractic patient, that's not typically the way it is. Now, in a medical doctor's office, when they're seeing all kinds of different problems, then they will have a myriad and a variation of things in all of these categories, but not a chiropractor's office for neuromusculoskeletal and the same problem. It's not the way it works. So I'll say most likely it was patients progressing as planned, progressing as expected, continue as planned. Because remember the initial plan, what was my initial plan? My initial plan was the therapies that I was using And remember, your therapies are totally based on what you found with the biomarkers relative to the 3 phases of healing. Well, what therapy am I doing for inflammation? Well, what therapy am I doing for pain? Well, what therapy am I doing for active range of motion? What therapy am I doing, for muscle tension or spasm? So that was all in the beginning. That's where your initial treatment plan was. These are the therapies you're doing for the different problems, and I'm going to see you 3 times a week with these therapies, and we'll re-examine you in 30 days. And then everything else just moves on. Or if you change therapy, maybe, but again, these are the things that don't really change too much in a chiropractic visit. They change at re-exams, not day-to-day soap notes. When you're seeing somebody 3 times a week or twice a week, it's not the way it works. So same with intensity or the settings or even the position of a treatment. So if you did any modifications here, but I'm just going to tell you that my plan. And so when I talked in my soap note for that microcassette recorder, and I was on the plan portion, 90% of the time it said patients progressing as expected, continue as planned. Well, continuous plan means these were the treatment protocols, and this was the frequency that I was in the initial protocol. And so, in summary, here's a little example of a SOAP note. This is a very example of a common daily SOAP note with one diagnosis. So the subjective for the low back pain might be a scale of 1 to 10. It might be daily or irregular. The objective finding might be low back range of motion limited to 60 degrees flexion, tender at L5, scale of 3 on a scale of 1 to 10, L4, L5 fixation, restricted joint movement, and then lumbar muscle spasms bilateral. So that would have been the objective. And the assessment would be no change. Assessment stays the same. In other words, the diagnosis stays the same. And then the plan, progressing as expected, continue as planned. So you see the assessment and the plan for a chiropractic regular visit, 90% of the time never changes. Those are easy. The subjective part is relatively easy. You just get each of the different chief complaints and you quantify them with intensity and frequency. That's pretty easy. And then the hardest part is the objective part, where you do need 2 evaluation protocols. And the highest probability is range of motion and muscle. Those are the highest probability with a typical neuromusculoskeletal patient. So in how this would sound, so I'll just tell you how this would sound. And I'm going to go back to the example of the patient who had headaches, neck pain, and back pain. And I'm going to walk through how it would have sounded and how I would have done that SOAP note. So, hi Mary, how's your day going? Okay. All right, Mary, before we get started, let me go ahead and just document where you're at. So the headache scale of 1 to 10, Mary, where you at? 5, okay. And neck scale of 1 to 10, where you at? 4. And with the headaches, or how often do you notice them, Mary? Is it still constant, irregular, or still every day? Still every day. Okay, that's not good. And then with the neck, is that constant or irregular or every day? So it's more every other day. Well, that's better. And then your low back, scale 1 to 10, so that's a 5. And how often are you noticing that, Mary? Is that still daily? Is it every other day? Is it regular, constant, or irregular? Okay, so it's more irregular. All right. So that is how quickly I talk to the patient to get the information. I pick up my microcassette recorder. And so today's date is, I say the date. I'm dealing with Mary, and her neck pain or headaches, a scale of 1 to 10 is a 5. And the frequency is irregular. Her neck pain is scale 1 to 10 is a 7, and it's irregular. And her low back pain scale of 1 to 10 is a 7, and it's irregular. That finished my subjective portion in the microcassette recorder for the subjective portion of notes. All right, let me go ahead and check you, Mary. Sit right here. And now I'm going to check her. And when I say check her, essentially all I'm going to do, and everybody has a little bit of a different protocol, but I'm just going to do motion palpation, and I'm going to look for joint motion. If you want to check a little more gross range of motion or overpressure, you can. But definitely always check joint motion. That's the last motion that will clear up. That's the last biomarker that will clear up. Always check joint motion. And then muscles, joint motion, and tenderness. So I'm going to check Mary's neck. In my case, I'll check rotation real quick, left and right, see if there's any restrictions, check for muscle tension or spasms in the occipital muscles. I'm going to check her neck flexion left and right real quick for fixations in left or right. And then I'm going to go ahead and treat her because I have her sitting. I always started sitting, so I adjusted her left, adjusted her right. Okay, Mary, let me have you lay on your stomach. And then I'll just push down on left SI, right SI, L5, L4, L3. And while I'm doing it, I'll say, any tenderness, Mary, tender, tender, tender. Every time I'm pushing in that joint and going to another joint, I'm eliciting a response. Any tenderness, I want yeses or nos. Any tender, tender, tender. And then I'm also checking for fixations as well as that when I'm palpating, I'm checking the muscles. So I check the muscles. There's some fixation L5S1. There's some muscle hypertrophy spasms on the right erectors, and she has some joint pain also. All right, I'm going to go face me on this side, Mary. Adjust her. Let me see the other side. Adjust her on the other side. The treatment's done. All right, Mary, that'll do it. Let me have you sit right there. And that's exactly what I said. I told her it's done. Let me have you sit right there. I picked up my microcassette recorder, and this is how I finished my soap notes. Subjective portion of Mary's soap notes, C5 restricted on the left rotation, slight tenderness on the left mastoid process, some muscle spasms, occipital muscle spasms, bilateral, C5, C6 fixation, especially left lateral fixation, muscle tension and spasms from C1 to C2. On the erector muscles on the left, posterior, and then L5 tenderness, muscle spasms, bilateral erectors from L1 to L2, specific tenderness at L5. Assessment, I'm done with the objective. Assessment, same as patients progressing as expected. Plan, the assessment remains the same, and under plan, patient remains the same. And whether I'm seeing her 3 times a week, twice, because remember, I already had those in my initial notes. So I'm just going, remains the same from the previous notes. Remains the same. That was my soap note. I just told you exactly how I did a 7 to 12 second soap note. And I covered all the metrics, all the biometrics, and I did it legally. Any questions about the soap note?
Paul, I got quite a few questions.
Number 1.
Do you ever talk about the quality of the pain in the subjective, sharp, dull, burning, tingling?
In soap notes, no. In the original consultation, yes. Soap notes, no.
What about the visit?
Now, wait a minute. Let me follow up with that. See, this is one of the big problems and differences with chiropractic and medicine. Chiropractic sees the same problems, and now we're treating that problem for consecutive visits. Medicine isn't typically that way. There's different problems that you're seeing at different visits. And so can you see how if there's different problems at different visits, you will have to do more of an extensive evaluation and management?
Yes.
But you do not with chiropractic, because that is not the typical chiropractic scenario. You've already made the diagnosis. You've already done the history. You've already done the consultation. You've already done the exam. You've already got all that information, and now you have the plan. Your plan is, okay, I'm going to do this for pain, I'm going to do this for inflammation, I'm going to do this for motion, and I'm going to see her daily or 3 times a week or whatever, okay, whatever frequency. Okay, you're done. And now all I'm doing is slightly adding to it for the regular visits called soap notes, the daily notes. And then the re-exam is when I go through and evaluate all those factors again, OPP, QRST, with an emphasis on frequency and intensity. But the soap notes, no, because we're not seeing a different problem every time they come in, so I don't have to do a complete workup every visit. Does this make sense?
Yes.
This is a huge difference between chiropractic and medicine with soap notes. Soap notes for chiropractors are easy. I just explained how easy they were. Scale of 1 to 10, frequency subjective. The assessment essentially stays the same for the regular visits, and the plan stays the same for the regular visits. Then the only thing that you have to consider yourself with legally is 2 evaluations for the objective part, and I just told you which ones I would do if I'm a chiropractor, and 91% of my patients are neuromusculoskeletal. It's range of motion. You got 3 ranges of motion to evaluate. Definitely always include joint motion because it's the last motion that will clear up. If you want to include gross range of motion or overpressure, include it. But they will go away a lot quicker than joint motion. And then go ahead and document the muscle component with any type of pain or restriction. And that is it. That is how and why a chiropractic soap note is so much easier. And nobody, can you see how I didn't have to stay after to do notes? And I was done. And by the way, I wanted that patient to hear me. In other words, when I finished with that patient, I said to the patient, wait just hold 1 second, Mary. And I literally hit my record for my microcassette recorder. And I said those objective assessments and plans in 7 to 12 seconds, turned off the microcassette recorder and said, okay, Mary, you can go on to therapy now. And I was done. I was totally done with those soap notes, and they were totally qualified. I did not have to sit around at the end of the day and do soap notes, or between patients, do soap notes. Next question, Rob.
Again, with the subjective, you have to tell them if it's acute, subacute, chronic, maintenance, supportive care.
Well, this becomes more important with Medicare because you're only supposed to be treating acute patients. So if you're talking about Medicare specifically, then yeah, you better make that notation.
Mm-hmm.
But if you're talking about the other, because that's how Medicare is a different animal, you know that.
Yeah.
For any other type of patient, I just listed what I told you. I listed severity and frequency, and that was it.
Okay.
Now, I also want to remind everybody on this call, most of you guys know I had all of my records subpoenaed, and I was falsely accused of violating HIPAA. I'm the only chiropractor who beat the U.S. government for not violating HIPAA. I was accused of violating HIPAA. So all my records were subpoenaed. Now, do you know how much I was fined, Rob?
Nothing.
Nothing. So you think you might listen to who's talking?
It's just that you go to the seminars and they're saying things have changed with the notes.
The only response I would say to the seminars is the seminars teach you to write soap notes like you're a medical doctor and you're practicing medicine. That's the only thing that I can say about that.
Right.
And that is not what we do. We are not regularly coming up with every time we see patients, it's not a new problem with a new diagnosis. That is not the chiropractic profession. So I will say in the assessment, same remains the same. I told you it's the re-exams is where I'm looking to make those changes unless something major happens.
Okay.
It's the re-exam is where I change the diagnoses and the treatment plan and therapies and frequencies. It's the re-exam re-report, not a day-to-day soap note, a micro trend. Those are called micro trends. So there is a huge perspective and difference. Yeah, I mean, I remember when I first started, learning about soap notes, and especially when you take a seminar that gives soap notes based on Medicare. I remember walking out of there thinking, why am I even practicing this? there's no time to even practice if you got to write all these notes.
Exactly.
I remember thinking how ridiculous this was. And then I filtered it down. I'm going, wait a minute. What are we really dealing with here? We are not medical doctors that see different patients with different problems every time they come in. So, next question, Rob.
Now we're in the objective. Do you have to quantify any of those findings, like say the muscle tenderness?
Yeah, try to quantify. Yeah, you want to try to quantify everything you can.
Okay. Now the assessment, what about percentage of improvement from visit to visit?
No, I don't. That's what the re-exams are for.
Okay. So you never say same, better, or worse, anything like that in your assessment? It's just progressing as expected?
90% of the time I told you it was progressing as expected. If they weren't, then I said it. I said, if the patient, patient had a minor setback, had problems today, there was a flare up at work, then I would say it. But 90% of the time, everything just kind of went as normal and the patients progressed.
Right. Now this is a big one that they're really telling us about, is the activities of daily living. You have to, like for say sleep, you have to tell them how they're improving with their sleep every so often.
Yeah, that's the re-exam also. That is not part of the SOAP notes.
So you don't need to put that. See, that's the thing. They're telling us you need to put that every visit.
No.
Okay. And then what about with the plan? Don't they want to know what happened on that visit, like what regions you adjusted or what therapists you did?
I already documented it in the beginning. I already said in the beginning what I was treating, what the diagnosis was, what therapies I was using, and why I was using them.
Okay.
That was all in the very beginning. And from that point on, it stays the same until I change the treatment therapies and the frequency, and I don't make that determination with micro trends day to day. I make that with re-exams, major trends, not minor trends.
Okay.
Day to day, it fluctuates. It can go up or down day to day. I don't give a shit. What I care about is the big picture. That's called re-exams.